Thank you, everybody, for attending and discussing outpatient IV infusion, the development of a regional center of excellence. I'm one of the founders of Community Infusion Solutions. We were developed back in 2008. I'm an epidemiologist by education, and as I was going through graduate school way back in the early 90s, I worked at a children's hospital and as a patient manager. And what I saw was that patients were coming from rural areas into centers of excellence, university hospitals, which is where I was at. And what I saw was that they were able to get better in the hospital, but then when the hospital discharged them to their rural environments, to the rural homes, that there was a problem with that care continuum. And some years later, after finishing fellowship and so forth, I landed at a hospital in Dallas, Texas, a large, big urban hospital, and ran a large infectious disease group and a large home infusion company. And certainly a lot of those rural patients were coming to our facility in Dallas. And I saw the same issues. I saw rural patients that were readmitting with infectious related things. And a large piece of that was simply that they were not adherent with their infusion services. And so our company, Community Infusion Solutions, was founded to address that very topic and to begin to develop outpatient infusion programs in rural community hospitals. So let me just go ahead and jump right in. So our agenda today, and we'll go through this quickly, is a little bit about Community Infusion Solutions, which I've mentioned, and we'll talk about that. What is an infusion center of excellence in and of itself? Why do you need one? Why is it relevant in today's rural world, in today's healthcare economy? How do you create one? A use case, and then we'll talk about next steps for your own IV infusion center of excellence journey. So I had mentioned our company was founded in 2008, and again, really wholly focused on rural hospitals. Myself, I'm an NRHA Fellow. I was fortunate to be chosen to go through that program back in 2014, and I took it really seriously. It was really the only way that I could really gain an understanding of the challenges that rural hospitals face, both in their patients out migrating, as well as just the different kinds of services that the hospitals wanted to provide, and then trying to come up with programs that would be relevant for them. For the population that we take care of, we have a 90% patient adherence rate, meaning that patients that are prescribed 30 days of IV antibiotics come to the infusion program on average 90% of the time. And for that drives a lot of really great things, to include referrals and as well as just outcomes for patients. We generate a lot of money for rural, and again, that was one of our big missions, was to keep that money in the rural communities. So $70 million annually through these infusion programs, these centers of excellence. But again, want to teach and learn again more about what a center of excellence is and how that could work for your communities. So the definition of what a center of excellence for infusion is, and I'm sure lots of people, organizations would have different definitions for what this is. I did my fellowship at Johns Hopkins in Baltimore, and at the time we were developing a center of excellence for chronic pain management. And ultimately, we tried to develop similar metrics, something very simple that could be calculated for, again, rural hospitals that we work with. So for a center of excellence, it really relates to two elements. One is that 40% of the volume and revenues are driven by out-of-market providers. So these are providers that are, again, not within your local markets, but refer patients to you. That said, these are your patients. These are patients that live, go to church, and go to your hospital currently. They're just not going to your infusion program, and they're going outside of your market for specialty care like GI or rheumatology or neurology, etc. The other element is patient adherence. So patient adherence has to be at least 90% in order to reach that center of excellence goal. And someone would say, well, if it's in a rural area, The social determinants of health are challenging, so that must be very difficult. And the answer is that it's not. It does require an organized plan in order to be able to reach those numbers. And we'll talk about exactly how we arrived on those, and then how hopefully that would be helpful for your communities. So within that Center of Excellence model is a defined outpatient IV infusion program. I visited hundreds and hundreds of hospitals and had lots of discussions around antibiotic stewardship programs and just some of the challenges that hospitals had around patient adherence. And one of the big pieces is that an outpatient IV infusion program, a Center of Excellence, it needs to be a cost center. It needs to be something that's tracked, something that it has a very specific flow. That adherence number of 90%, we've done lots of focus groups around that to try to understand why patients in rural Mississippi or in the state of Washington or in Oregon or in Michigan, and why those patients are adherent. And really the central theme that comes back is that when the patient wakes up in the morning, they know exactly what's going to happen to them from a timing standpoint, from a location standpoint. So when a patient wakes up in the morning, they know exactly that they're going to get up in the morning. They know their IV infusion services for antibiotics, for instance, are going to last about an hour and a half. That patient is going to go to registration only once. And then from there, they're going to go directly to the outpatient infusion space that's defined. They're going to sit down. The nurse will be prepared and ready for them because everything will have been coordinated and scheduled. That the pharmacy is prepared, that the medications are on their way as soon as the patient is registered and is in the space. So again, those are just examples of trying to help patients demystify the complexities of our hospital world. So to put it into a little bit more specifics, we always begin a program with a data analysis. As an epidemiologist, being able to take data and then begin to plan a process that looks at time values and looks at outcome measures and things like that. So that's the first piece of it, and the development of that pro forma. And we'll talk about what that pro forma will look like in just a moment. The market development side of this is that the infusion program needs to have a defined person who is accountable for the account executive activities, or those sales activities, those marketing activities. For our team, we have a defined person that's educated and trained on that front. And when they're doing their market development, they're not only talking with the local providers, but they're also, we're using Medicare data and other information to know exactly where patients are going for their rheumatologist or for their neurology. And so that market development piece is fundamental. Again, that account exec is going to be going out and meeting with those people. Also, that account exec is providing the referral forms, something that's that needs to be updated from time to time, and just makes for a good opportunity to discuss with the providers and their team. There's also a social media component that goes into this. Certainly, we live in an internet world, and so as such, the patients, when they get a diagnosis and the doctor says, well, you're going to be on Remicade, likely the first thing they're going to do before they're out of the parking lot is to Google Remicade. So within our infusion programs, when they do that, it's going to geocode it, if you will, so where the patient, because of where they are geography-wise, it's going to give them some social media elements. It's going to put them on the website for the facility. The facility on their website will talk about outpatient infusion and have a message from the nurse talking and just really welcoming patients and letting them know that this is a service that they can get done locally and that they don't have to travel for that. So those are elements of the marketing side. Case management is really the cornerstone of what an infusion program has to offer. Certainly the nursing and pharmacy elements are very important, but again, the goal is to try to get that patient there, to keep them adherent and to keep them on track. Again, realizing that patients are challenged by a whole host of different external forces. So the case manager is the head of a team. That team includes looking at the order, making sure that it's valid and that it's signed, that it's dated. And there's a quality component that goes into that, and it's very specific, and there's certain elements that you want to keep track of, again, to make sure that not only the patient is in the know and that the case manager has reached out to the patient and spoken with them, but also that the provider's office feels very integrated. This is a very high-touch service. We did a study looking at the number of times that the case managers will speak with patients or the insurance company or the different elements within the infusion program, and the touches, believe it or not, is on average is 8. So in this particular model, the case manager is also in charge of scheduling. So making sure that the patient knows when they're supposed to be there, but also that the facility, if they have 340B, for instance, or they don't, that the pharmacist knows when the patients are going to come to make sure that the medications are there and that to ensure that the patient's visit is timely. The insurance verification and pre-authorization is definitely one of the one of the big secrets. A lot of facilities that I speak with initially, they look to the provider office to complete the insurance verification element. But the piece that's a little challenging on that is that the provider's office is very busy. The nurse likely that's that's completing the order and getting it out is also very busy, and they're going to look for the least challenging path to that. So we have our hospitals will take care of that, and in fact, that's something that our company takes care of. For the facility, and that's a huge element. It definitely takes some time, but then again, the hospital is going to be providing the infusion services. They're going to be billing these out, and if there's issues or denials relating to that verification or insurance authorization process, it's important to have that recorded so that if there are issues, that it's easy to go back and to work through that. The case manager, again, is going to lead that team. So before a patient is going to be scheduled, this element, the insurance verification, the quality around the orders, making sure that the medications are there, and making sure that there's a spot for the patient to be infused are fundamental pieces in order for the success of the program. The financial review side is that during the insurance verification process, or you certainly have your managed care agreements that you have sitting there, you'll know exactly what it's going to pay. So in the communication with the pharmacy team, one would know exactly what the revenue is going to be, you know what the costs are, and then if there's any other issues around that, then the case manager then gets involved as well. So for instance, if a patient is prescribed Remicade, again, using another example for Remicade, if, for instance, the reimbursement is not a break even or it's not profitable, then the case manager will look for other alternatives that are in the same class and trade, biosimilars, for instance. And so then the case manager then reaches out to the provider and has a conversation. And this isn't something that's unusual. It's something that's done all the time. But needless to say, it's just an education process and very fundamental. So then at that point, the patient's put on a biosimilar, and then the financial review piece looks good, and then the patient's scheduled, and everybody's off to the races. The other element is a revenue cycle support side. So if there are issues relating to denials or denial management, that somebody within the infusion model is familiar with infusion drugs, aware of medical necessity around the payer, and could be able to discuss that. Because of course, without the ability to bill this correctly and to get it reimbursed from our friends the payers, it's just fundamental. And then at the end of the month, certainly a monthly reporting that specifically looks at that cost center to make sure, again, that the program is hitting all the marks. That's not something that's evaluated every 6 months. It's something that's done every month to evaluate the growth and then to give feedback, again, to that market development team. So why is the need for outpatient infusion center of excellence in today's world, in the rural world? Well, certainly we know that inpatient revenue is declining. There's lots of pressure to move more things into the outpatient arena or into the home environment. And so this is a great program that has very low entry points cost-wise. to hit exactly that goal. Growing severity of outpatient services. So as patients are coming from the inpatient side into the outpatient side, trying to identify services that have greater revenue streams, such as biologics or chemotherapies. So it works really well for that element as well. The other piece is that infusion services, and not just in rural hospitals, but in urban as well, that this isn't really something that hospitals are really focused on. I think it was very much viewed, and then again, this is from what I've heard from hospitals over the last decade, is that infusion services are like diabetes education. It's a great program. It really needs to be there. The community needs it, seeks it, but it's really not been something that's been prioritized. And so therefore, it's the #1 out-migrating service line for most hospitals. For the hospitals that are sharing this webinar with us today, just our hospitals, again, 18 hospitals, $7.2 million in Medicare out-migration that's occurring. Clinical labor is limited, so certainly nurses are, there just aren't enough of them. They're nowhere near. So making sure that the program maximizes the clinical labor and minimizes the paperwork and the insurance components and really the tracking and the following and the management of the patients, all within the Center of Excellence model that we discuss and that we implement. That's a cornerstone, especially during COVID and post-COVID. And the last comment is just that the window of opportunity is closing. So oftentimes I'll go into a community and at some point maybe there were imaging services or an MRI service that was that program was provided or handed over to another group within the town, and that's difficult to ever get that back. There are organizations from the outside that are not as focused on rural, that are not focused on the community as you guys are. And so, as with everything else, if there's opportunity, if there's financial opportunity, if there's out-migration or low market share, then that opportunity for an interloper, for instance, to come in from out of the market to pull revenues away from your community. So how to create, again, this Infusion Center of Excellence. So today, as I mentioned, we have 18 hospitals sharing the webinar with us. The average market share for facilities that we're discussing today is 12.2%, with an average out-migration, annual out-migration, only looking at Medicare, of about $400,000. So the first element is to evaluate the opportunity using data, using the data that you have. Understand what the population is. Infusion services don't take care of patients across the entire spectrum of what your hospital takes care of, like for instance within their lab. But needless to say, this is something that can be done very timely and then give you the information that you need in order to develop what that program will look like. And I have an example of what a pro forma will look like. The other element is to begin to think about a narrow network. Again, very common hospitals will share with me that there is maybe there's a hospital down the road. Well, they'll never give us those patients. They'll never return those patients. Or there are 2 or 3 neurologists in the big city. 2 of them have their own infusion programs. 1 of them doesn't. So beginning to think about the organizations or providers that are willing to send patients back to your facilities. Again, revenue is very important here, but then you also have the public health side of this, which is patient adherence. Patients that, for instance, a Crohn's patient, Crohn's patients that are not adherent to their infusion therapy cycles, Medicare suggests that it costs Medicare an extra $100,000 a year per patient. So that narrow network is really important for the patient, for their quality of life, and just for the quality of their health care. So implement, again, a service model that has heavy marketing that's tracked through a CRM, so you know where that marketing person has been and looking at that success. And again, that all builds into that narrow network. And then that case management component that's really focused on outcomes. So in the pro forma, the hospital looks at all patients that have come through your doors for a 12-month period. So this includes your rural health clinics, this includes your ER and your surgery center, everything. Because again, a lot of patients that have chronic diseases that could benefit from infusion services, they're using your hospital for a host of things, lab imaging, inpatient activities, but it's probably not something that you probably have targeted that particular population. So this is a good way of doing it. The way that we do it is that we've developed an analytics tool where we take all this data, and for this particular hospital, it's about 60,000 lines of data, and then we put it through a model, and then ultimately at the end of the day, it gives us a good idea, probability-wise, of which patients are likely to come to the infusion program and which ones are probably not. Not all cellulitis patients get infusion therapy, but if the patient, this is an example, but if the patient has diabetes and peripheral vascular disease and they've been in your emergency room twice within the last 12 months, then that's probably a pretty probable patient that could really benefit from the program. So this is again an example of a pro forma. This is the executive summary. So it gives the actual cash flow, what the payments are, what the profits are, and then on our side, if we were doing the program, then what the setup fee and what the cost side of that is. So this is what the pro forma looks like. As you're looking down on this left-hand side, and I hope you can see my cursor, antibiotics, anemia, and so forth. If you were to, for instance, get your medical staff together and you're talking to them about this new infusion program that you're really excited about, and you might mention a few drugs, likely drug therapies, but the way that it works best is that each of these elements are service lines within this particular product. So antibiotics, from a marketing standpoint, that could include pulmonologists, that certainly would include family practitioners and nurse practitioners and PAs, but it could also include podiatrists that are taking care of diabetic foot infections and things like that. And so from there, you begin to budget each of these elements in order to achieve the pro forma that we have. Expected payments is, for us, we usually base it off of a Medicare OPPS fee schedule. So we don't include the commercial payers for this particular analysis, just simply because we don't know really what we know what the payer mix is in general, but again, to get it down to the specifics, and we want this to be conservative. Certainly most people want a conservative pro forma. The drug is exactly what you might expect. If you have 340B, then it includes that. If you don't, then it doesn't, and certainly where there are orphan drugs and some other elements around that. And so that's something for us that we're familiar with and that we help with. Total operating expenses at the end of the day include the operations as well as other elements. And then you ultimately end up with a profit and loss statement and an ROI. Inside of that, you'll notice that this number here, 5.2%. So as I mentioned before, just because you have, say, 10 patients who have multiple sclerosis, it doesn't mean that all 10 of those patients are likely to receive infusion services within your organization, because there's a whole list of reasons why some patients choose not to receive that care, or they're going to go outside the market. But again, the goal is a conservative pro forma. Another element that really drives referral volume is having some type of transparency around the patient's experience. So when the patient, in the form of an adherence report. So this is something, this particular form here is something that we share with our providers that are referring patients into the outpatient infusion programs, so that this can be then put into their medical record, that is the patient's medical record within the provider's EMR. So when the patient comes in, as it was when I was at the big hospital in Dallas, and the patient says, well, I don't know why the medication's not working for me. My body must be just simply different. Well, if the patient's not adherent with their therapy, then they're not going to benefit from that. And so this is a key element that, again, as we move forward with kind of a health policy standpoint, this is something that I think is going to be more seen in not just outpatient infusion, but also in other elements. So patient compliance reporting directly to those referring providers. The other element is that this is an example of, and something that you can share with your referring providers, that when you have a principal care management model, and that's really using case management for a particular chronic disease like cellulitis or osteomyelitis or something like that, that not only are they referring that patient for care, but you're also giving them a case management element that's very specific, and the adherence report is the outcome measure that most providers have interest in. This is also a great discussion point for the account executive who's out there marketing. Did you get your compliance report, your adherence report? Did your provider find this to be helpful? And again, what we've found in just talking with our account execs is that the providers, they like to discuss that. The last piece, just with regards to around trying to improve adherence, is to do a capture rate analysis. So do another deep dive. Take a look at your patient population that's coming through, and then try to understand and try to answer, well, why didn't these patients come through the outpatient infusion program? What was the barrier? What was helping, preventing them from coming in? Because this is an example. So this is a patient, and this is a hospital in Tennessee, and we had an outpatient infusion program with them. But again, through this capture rate analysis, what we found was that, for instance, here's a patient who has type 2 diabetes. They have osteomyelitis and they of the left ankle. They came in through the emergency room for pain, I'm sure, back in, was that March? About 30 days later, they came back into the emergency room. At that point, they had already gone to a large hospital and had an amputation. So they had amputated their left foot. And then from there, what we can see is that, again, that care continuum, there was a problem. There was something that's broken inside of that. So oftentimes when you do your capture rate analysis, or when we've done it, a lot of these patients are very, very ill, and just for some reason, the flow or the process just has not put them into a very intensive case-managed outpatient infusion program. So again, this is a great tool to illustrate. So actual impacts of this model is that looking at 3 hospitals, so 2 PPS hospitals and then 1 critical access hospital, and what you can see is that the revenue increase was rather significant. And again, if it's considered a community service and it's not in a cost center, you can't really track it. But then as you begin to track it, then you find that you can be more efficient in your marketing activities, in your communication, and in your engagement with not only the patients but also the providers. The other element is just look at how the patient adherence rate or the compliance rate jumps from 38% to 92%, 46 to 88, and 29 to 93. And again, these are not uncommon. It's just a matter of, again, having that flow and that process very well established. So as you begin to scale your program, you're getting those benefits. So one question that often gets asked is around site of care initiatives with the payers. So say, for instance, that you try to get the prior authorization, and then the payer comes back and says, well, we want this done somewhere else. And what we've found is that where you advocate for patients, and since the advocacy on our side is done through the case manager, who's very familiar with the medications, who's very familiar with the patient's case and the provider, with that advocacy, we're able to overturn 85 to 90% of all site of care initiatives from the payers. And ultimately, over time, the facility then has the ability to go back in a contracting environment to say, look, these are the outcome measures that we have. This is the adherence rates that we have. And in many cases, facilities have the ability to improve their managed care contracting, again, because they have the ability to, again, show that value. Another question that often gets asked is just around the nursing side. Is that is it difficult to find infusion nurses, or sort of what's the environment for those infusion nurses? And really the comment that has come back is that the infusion nurses are seeking some type of support around their infusion program. In other words, somebody to take on that paperwork element of it, so that they can, again, practice their trade and take care of the patients efficiently. The other nice side of that is that since with very careful scheduling of patients, in other words, trying to get patients blocked within a certain time during the day, maybe have your biologics on certain days of the week, that really aids the nurse as well as the pharmacy team, so that they can also continue to manage their own inpatient sides, as well as this outpatient infusion piece. A common comment is that the infusion nurse would say, there's no way that I would be able to see these patients without, again, this type of support in order to try to help. What we would like to do, just as an offering, is that our company would like to do a deep dive pro forma for your organizations. What is included inside of that is a non-disclosure agreement and then just some data elements. The non-disclosure agreement, you likely have one that you guys probably use with other partners, but once the data is shared with us under that NDA, then we would come back to the organization and be able to share that level 2, or what we call level 2 pro forma, which is exactly what we had shared before, so that then you have the ability to take that to your board and to answer questions just about the idea of scaling the outpatient infusion programs that you have. We recognize that all hospitals in the world do outpatient infusion services. I was in the Peace Corps for a while, and in West Africa, and even in the most rural areas, they were doing some type of infusion services. But needless to say, being able to identify the population and then being able to scale that program, not only in volume and revenue, but in patient outcomes and how this engages with, for instance, your antibiotic stewardship programs. So that's the kind of information that we would be able to share with you. And I know that Chastity would likely be in touch, sharing some communications around that. Please reach out certainly to Chastity or myself. I know Chastity will share my information. We'll be responsive. And I hope you have a wonderful day, and thank you.